So today we will be starting consultation skills, and with that we are going to touch upon different aspects, or how are you going to interact to the patient in a way that is more effective. First of all, you first need to understand why is it important to have a very good consultation. So when we finish that, we should know the definition of the consultation. We should know what are the different types, or you can say what are the different styles of consultation, and appreciate the importance of effective consultation. So there are two types of consultation which when you come across with your patients, you happen to see that one consultation is good. Okay, you're taking the history from the patient, but the patient is not very cooperative, or you think that there is some gap between me and the patient. And there are some patients who are very open to you, and they are very comfortable, and you are very comfortable talking to them. So that this is how you feel that okay, now this is an effective consultation. And understand the utilization of each type. So we will see the different types or the different patterns of consultation. How are you going to approach the patient with different models, and we will see the uniqueness of each model, and then recognize the barriers. You first need to find out what are the barriers that you and your patient is having, and then recognize the essential skills for the effective consultation. So you require some specific or essential tools, and what are these tools? We will go and look up that, and modify your consultation. You have a chance, and you have the ability to actually change what you want according to the needs, or according to your needs, your application, and the patient needs, and context, the social context. If you look up here, consultation is like a roadmap. If you want to reach to somewhere, like in a very big city, if you want to reach to Houston, then there are a lot of ways that you can carry on. You can go through this way, you can go through that way, you can go through that way. So whatever is the way you choose, it's okay, as long as it is reaching to the same destination. All right. So if you are acquiring any consultation model, but as long as you are reaching to the patient very effectively and very constructively, your job is done. So any path you can take. So consultation models are like the path, and the main objective is the patient satisfaction. So before we go on to the different models, we will say why it is important. It is a central act of medicine, because medicine revolves around the kind of consultation you and your patient is having. So communication skills are a core clinical skill. So this is because consultation is your communication, and communication is the core skill of the medicine. And diagnosis made more frequently from interview the data than all other sources added together. So if you have a very good history, very perfect examination, you are going to diagnose patients on very good. So doctors conduct up to 2 lakh interviews over 40 years of career. So we as healthcare providers, we frequently interact with the patients, and if you don't know how to interact the patient effectively, your consultation is not going to give you more benefit. So why do we talk about consultation? There are some evidences about it. So if you see here, doctors identify their patients' problems more accurately. So if you have a very good consultation, the research says that the patient's problem that you're going to solve, they will have a better understanding. Patients are more satisfied with their care and can better understand their problems, investigations, treatment options with fewer complaints. So decrease lawsuits and increase patient satisfaction. So these are your tangible outcomes that you will get from these consultation models. If you have a very good consultation skills to the patient, there will be decreased decreased complaints, decreased lawsuits. So this is going to increase the patient satisfaction. Patients are more likely to adhere to the treatment. The main problem of the healthcare provider is whatever you are giving to the patient, whatever advice you are giving to the patients are not very keen to follow that. And the reason is we don't know. You have told the patient that if you do not control your diabetes, you're going to have this. But in spite of all these vibes that you give to the patient is not adhere to that. So because the problem is not with the knowledge, the problem is with the way we communicate with the patient. Patients' distress, their vulnerability to anxiety and depression are lessened. So if the patient is very depressed, if the patient is very anxious to something, if you have a very good communication skills with a confident mode of action, you are going to handle these depressions and anxieties. Doctor become more time efficient. So you also will have very less time in order to create a very effective consultation. An effective consultation doesn't need to be a long consultation. An effective consultation should be a focused, friendly, constructive consultation is your good consultation, and it can be as minimum as 5 minutes or 10 minutes. Doctor's own well-being is also improved with these. So these are all evidence-based that consultation models or the effective consultation is going to benefit you as a physician and is going to benefit a lot patients as the receivers. It is more important to know what sort of a person has a disease than to know what sort of disease a person has. So usually it matters that what kind of patient you are dealing with, rather than what disease you are dealing with. As healthcare professionals, we tend to focus more on diagnosis and more on treatments. But the truth of the matter is, if you know your patient, you can actually, because you have a lot of management options that are maybe different, that suits different person. It's not about right or wrong. It's about suitability, feasibility, applicability. So if the patient thinks that it is more feasible, more doable, more applicable, it suits me, it's okay as long as you give one medication or the other medication. If both have the good outcomes, whatever is suitable for the patient, you are going to prescribe that. I'll give you one example. There is a drug in diabetes. You give some drugs, you give metformin, and you can also give sitagliptins. Sitagliptins are also, they are new drug and they both are very good. But as the first line, if you're giving sitagliptin to a patient, sitagliptin is an expensive drug, and if the patient doesn't have any insurance, so he might be very reluctant to buy that. And if you do not know, or you cannot guess that the patient financial status is not such that he can afford that, maybe he won't be able to adhere to that treatment, and you're wondering why he's not buying these drugs, or maybe the drug is not available in his area. So these are all things that you need to consider before prescribing the medication or before giving any advice. If you're giving an advice to a patient who works from 8 to 8 or 9 at night, and you ask him to do half an hour walk, and you go to gym, you should go to swimming. So he will say that I do not have time. How can I incorporate all these things? These are all good things, all facts, but you need to contextualize your conversation and you need to make it more feasible to the patient. How you are going to do it? There are some tools that are available and you can choose from any of them. So if we see consultation models, we have physical, psychological and social. So now we will discuss about different consultation models that they have proposed, and you can pick different consultation models, you can pick tools, or you can pick things from them, component from them, and make your own style. The RCGP model encourages the doctor to extend his thinking practice beyond purely organic approach. So you give physical aspect, The physical aspect is the the problem, presenting complaint, history of presenting complaint, and so on and so forth, the whole analysis. And then there is psychological. So you also need to identify what are the psychological problems that the patient may have, and you might want to discuss that. And also the social, we have discussed the social thing. Maybe it is not maybe it is not the drug that you're prescribing is not available in his area, or it's very expensive. So you need to be very careful in this. So that's one thing. So when you start your consultation, try to think in not just only physical things, but also psychological and social well-being or social aspects of the patient. There is another model called Stott and Davis. The exceptional potential in each primary care consultation suggests that 4 areas can be systematically explored each time a patient consult. So now what is happening in these models? They are dissecting the patient and doctor conversation into different parts. And if you analyze your consultation or interaction with the patient, you can also dissect all these things. And there are some important dissecting points which you may miss or you can acquire. For instance, in Stott Davis, what they describe the consultation model is, number one is management of the presenting complaint. This is very basic, right? You have some presenting complaint and you're going to manage that. Then modification of help seeking behaviors. So when you are doing your consultation, this is in the non-pharmacological treatment, you are going to educate the patient about these are the danger signs, when this happens you need to come back, or for this you need to go to these centers, for physical activity you can do this. So you are actually modifying the help seeking behaviors. Then management of the continuing problems. There are some new problems and there are some chronic problems that are going on from the past, so you also need to consider in that. And then opportunistic health promotion. What is that? Opportunistic health promotion is you have the opportunity that you can intervene. Like the patient is coming to you with chronic cough, and you may be diagnosing the patient with COPD or just chronic bronchitis. And when you take the history, the patient says that, doctor, I'm also a smoker. Although he does not want any advice from you as a smoking cessation, but you as healthcare professional has the opportunity to intervene this. How? Intervene in a way that should not be that should not breach the confidentiality, that should not actually make the patient more insulting. In a respectful way, in a professional way, you are going to deal these issues. So if there is smoking cessation, or this is an opportunity that you can counsel something about that. And if there is a child who comes to you and you think that for some reason, and then you find out that he is not immunized, so you maybe counsel on this. Or if the child which you think that the hygiene is a problem, you can intervene and give some words about hygiene, so on and so forth. Think about these opportunities in the patient. Yes. No. Opportunistic behavior, health-seeking behavior is because health-seeking behavior, this is help-seeking behavior. Patient is not coming to you for this help. Is not coming to you for smoking cessation. Doctor, I would like to quit smoking cessation and I'm here now. It depends on the context. Which context you are talking about? Help-seeking behavior also differs, and also the opportunity is also going to differ. The only way you can get these opportunities that you will when you think in this direction. So it's like a zigzag road, and you are going to complete the journey within these parameters. There is another consultation model which is called Brine and Long. Doctors talking to patients, 6 phases. So what they have dissect the consultation model is into 6 phases. First, the doctor establishes a relationship with the patient. So this is a rapport building. So with the present, the other model has started their conversation with the presenting complaint. But obviously, when you are doing the presenting complaint, before that you are actually making a rapport. So first, the relationship. Second, the doctor attempts to discover or actually discovers the reason for its patient's attendance. And now they have added one extra step, that obviously within the presenting complaint, this is implied that you are going to make some rapport building. So rapport building, then presenting complaint and analysis of that. Phase 3, doctor conducts verbal or physical examination. So this is very clear. You do say history taking and then you do some examination. And then the doctor and the patient consider the condition. So now in the 4th phase, you involve the patient into decision making, or you can do the decision making, or you allow the patient to make his decision. The doctor and occasionally the patient detail further treatment or further investigation, and then the 6th phase is consultation is terminated usually by the doctor. So you ended up your consultation. So that's another 6 phase stage in Brian Long. So you see here the way the scientists have dissect the consultation interactions into different phases. They are just providing you different point of view, and you can choose whatever you want. Hellman's Fork model. It has 6 stages. What has happened? Why has it happened? What has it happened? That means presenting complaint, in other words. Why has it happened? Analysis of that. Why to me? So why did I have diabetes? Because there is a family history maybe, or because there are certain risk factors that are attached to it. So this is why. Then why now? Why now you are presented here with something happens like the wound is not healing maybe, or I'm having this chest pain, this is why I'm here. So what is the presenting complaint now? So why now? What would happen if nothing was done about it? So try to think in that way. When you are dealing with the patient, these are your own questions. You should reflect on these questions while you are interacting with the patient, so that you do not miss things. What should I do about it, or whom should I consult further? So if there are any things that requires referral, you would like to incorporate some other team members within these consultations. Transactional analysis. This is another concept. What is that concept? The concept is, we have been into these 3 roles as children, as adults, and as parents. So we usually have, or conventionally have, parental doctor or a childlike patient. So we assume that the patient doesn't know anything, and I am, as a parent, as a doctor, I need to dictate the patient, educate the patient, or not actually educate the patient, tell the patient to do that. Not educating, right? Not exactly educating, but actually telling the patient to do this, not to do this. Why? Because I'm said so. I have an authority to give you this kind of advice, and your obligation is to follow, not to argue things up. So this is a traditional kind of a consultation which has a lot of problems, because patients have their own, now the patients have their own sense of well-being and sense of thinking. So you need to consider this, that what is your relationship with the patient? Are you being very bossy parent, or you are being very friendly, discussing the problems right away and intervening accordingly? Then there is Pendleton model. First, to define the reason for the patient's attendance. This is again the presenting complaint, the same. Nature and the history of the problem, history of presenting complaint, their etiology, the patient's ideas, concerns, and expectations. So if you see here, this is very unique to this model. presenting complaint, history of presenting complaint. Obviously, before starting with the presenting complaint, you are going to do some rapport building. But there is another thing which incorporated in this consultation is patient's expectations, ideas. So what is this? The patient's ideas, concerns and expectations. Patient idea is what is his perception of the disease, of the problem, how is he seeing the thing. If he's seeing the thing as diabetes, that the diabetes going to be cured, like fever, like sore throat, so you need to correct this idea. Concerns, what are his concerns? Maybe he's not concerned of the treatment, but he's concerned of the cost. Doctor, what is the cost of this? Where am I going to get this? So address these concerns. Maybe he wants to do, if you are planning a surgery, his concern is, am I going to attend the wedding of my daughter, of my son? So address these concerns, incorporate his concerns into your management plan. Maybe you can delay it a bit. Maybe you can find some alternatives that are more feasible to it. So address these concerns, ideas, concerns, and then expectations. If I'm expecting that I'm going to be treated or cured with diabetes, these are wrong expectations. So try to correct that also. So while you are interacting with the patient, somewhere in between history of presenting complaint, examination, or maybe laying out some management plan or giving some investigations, you should need to address patients' ideas, concerns and expectations. We can remember this ICE, I-C-E. Did I as a physician explore his ICE, ideas, concerns and expectations? And if yes, then what are those and how? And the effects of the problems, consider to other problems, continuing problems, at-risk factors. So these are all things that you incorporate into your consultation model. But the ICE is something unique to this model, Pendleton models. Further explanation, with the patient to choose an appropriate action for each problem to achieve a shared understanding of the problem with the patient. So you are incorporating the patient into the management plan, and you, before going to the management plan, you first need to check the understanding of the patient. To involve the patient in the management plan, encourage him to accept appropriate responsibility. You are a physician. His physician is like a facilitator. He facilitates this patient that these are the options. What do you think on these options? Or this is the problem that I've come up on a conclusion. What do you think of that? Then the patient gives you his understanding. And then, okay, now we know that the patient understands the problem. Then we go into the management plan. So we have multiple things. Maybe we can do some investigations and start with this. But for instance, these investigations are routinely done, but as far as the management plan is concerned, it's not going to affect much. So do you want to get it done? You can ask the patient. And if the patient says, okay, no problem doctor, you can right away give me some medications. And this is something very safe. If you think that this is safe, then you may want to go about it. So things like that, you need to incorporate the patient on every stages to use the time resources appropriately. So neighbor, there is another model which is neighbor. He points out 5 checkpoints. One is connection, establishing the rapport. Within this, he has actually getting up all the presenting complaint, history of presenting complaint and all that. You connect the patient. Obviously, when you are connecting with the patient, you will find out all these things that are there. So he summed up and presented like as a connection. And then summarizing, getting to the point of why the patient has come, eliciting the skills to discover their ideas, concerns. So all of this, then you're going to summarize your whole consultation that, okay, I understood this. Then handing over. Patients and doctors' agendas are agreed, negotiating, influencing, and gift wrapping. So then you are going to handing over. The patient has said something to you. You have processed the information. you send it back to the patient as a summarization, and then when you summarize, the patient will give you maybe some extra things, and then you and your patient comes into the common agenda. Once you are in the common agenda, and then you can work on to the management plan. Then there is another very good thing is safety netting. This is a very unique point here. What is safety netting? Safety netting is very important and crucial in primary healthcare, because as we discussed earlier, the primary healthcare physician is dealing with benign problems, with different patients, different age groups, different agendas. Every patient is not a malingering patient. Every patient is not a manipulative patient. You think that he is malingering, he is negotiating, he is manipulating, but actually he has some problem. In order to differentiate between true patient and not very true patient, you must have to have a safety netting. What is the safety netting? Is if the patient comes to you every now and then for chest pain, doctor, I have chest pain, and you think you did ECG for the first time, you did some cardiac enzymes, and it was all normal. And then you ask the patient, okay, there's nothing in it. You all do echocardiogram and things like that. No risk factors, young patient, no smoker, no family history, and he has chest pain for 10 days. So chest pain for 10 days, you usually do not think of cardiac. So you refer the patient back, or you send the patient back by giving some treatments. And then he comes back 1 week after, then 1 week after, then 1 week after, and you presume that this time, the third time that he's here, he doesn't have any problem. He's just malingering. So I do not want to do ECG and waste all these resources and my time into it. And then you and then you give some medication and you send the patient home. But this time, unfortunately, this patient has this chest pain, which is cardiac in origin, and it's a typical chest pain.